So let me, I'll just formally start it and say everyone
Oh, great.
right.
Very nice, sir.
Thank you, sir.
This is a marriage dress for Raghavendra.
I welcome you all to this evening PGNAR, this digital seminar organized by Dermatologists Consortium of India. There's nothing else. We all are members of that. We all, those who are participating and using it, we are all forming a consortium. No political, nothing else. So I welcome you all. And this is today's speaker is Dr. Raghavendra Rao, whom we have put up a Rajasthani turban from our Rajasthani team has prepared a Rajasthani turban for that. And I take the privilege of giving him a virtual bouquet. So kindly accept our virtual bouquet from this. And
Thank you, sir.
Dr. U.S. Agarwal will be formally introducing Dr. Raghavendra Rao. Dr. U.S. Dr.
Yes, sir.
U.S.
Good evening, everybody. Yes, sir. Good evening, everybody.
Yes.
It is my proud privilege to introduce Dr. Raghavendra Rao, who is professional head, Department of Dermatology, Kasturba Medical College, Manipal. His areas of interest are vasoconstrictive disorders, pediatric dermatology, dermatopathology. He has been awarded with many achievements, including Commonwealth Academic Scholarship, St. John's Institute of Dermatology, London, UK, and BN Banerjee Gold Medal, Best Original Research Paper in year 2005 in Dermacom. He has attended as a scholarship to attend World Congress, American Academy of Dermatology Conference 2008-9, and he was past editor of the Indian Journal of Dermatopathology and Diagnostic Dermatology. He has to his credit 82 scientific publications and has contributed 10 chapters in different textbooks. I welcome you, Dr. Raghavendra Rao, for today's lecture and enlighten us the recent advances in AICD.
Thank you, sir. Thank you very much. Shall I share my screen?
Yeah.
Prayer.
It says host as disabled participant screen share. I think you have to enable me, sir. I think you have to give me permission to share my screen. It says host disabled participant screen sharing.
Sir, the prayer is pending.
Is it audible or not?
Yeah, it's audible.
It'll take 2 minutes only.
Yeah.
What's the problem?
I'm not able to share my screen. It says
Just a minute. Just a minute.
Okay, sir. Yeah.
after it finishes.
Yeah.
Sudha, sorry. लैंडलाइन में तो ध्यान नहीं आवाज ले लें तारी बाजी.
Well, now you can, Dr. Raghavendra, welcome once again and start this thing. Start sharing your PPT.
Okay, sir.
Right.
Is it visible?
Oh, yes, very much.
Yeah. So thank you very much, Dr. Dinesh Mathur, sir, Dr. Yas Agarwal, sir, and Lalit Gupta, sir, for this invitation. It's a privilege to be here talking to PGs and consultant about some of the aspect of autoimmune blistering disease. It need not be new. All the things that I'm going to speak is not entirely new, but I thought because PGs are there in large numbers, it may be useful for them, especially for their exams. So we already had, I think, a couple of lectures on pemphigus in this platform already by two eminent speakers, and why there is what's the necessary to have one more talk on pemphigus. So that probably is the question in your minds, and it makes sense because pemphigus is one of the life-threatening conditions that we are going to deal in our day-to-day practice. And there's a lot of new development that have taken place in the last decade, and it probably is worthwhile knowing about some of the aspect of pemphigus, which probably other speakers wouldn't have covered in their talk. So this will be the broad outline of my talk. I'll be covering some of these aspects. So pemphigus, as all you know, is associated with high morbidity and mortality if it's not treated properly. The mortality rates used to be about more than 90% in 1950s, and with the introduction of steroids and other immunosuppressive medications, mortality has come down to less than 5% now. The prognosis and treatment of pemphigus and pemphigoid group of diseases varies. So that is why we need to classify them, make a precise diagnosis before instituting the proper treatment. For example, the first line of treatment for bullous pemphigoid now in the European, according to European guidelines and British guidelines, is topical steroids, whereas pemphigus would require oral or systemic steroids from the beginning. And the other reason for knowing about this is there's a delay in the diagnosis of pemphigus. According to pemphigus support groups web page, they claim that there is a delay of average 10 months before a proper diagnosis of pemphigus was made. There are two reasons for delay. Could be because people are not aware of the conditions, especially the family physicians. They are not aware of the conditions, and then most of the time they fail to confirm the diagnosis because they don't know what test has to be done. Most of our patients, even today, they say that their family physician said it is chicken pox or something like that. So there is always a delay in the diagnosis of pemphigus, and it is for us to educate the family physician or primary care physicians about the need to refer these patients straight away to the secondary or tertiary care hospital or to a dermatologist.
Raghavendra, can you bit louder, please?
Okay, yeah. So there are many types of pemphigus. Is it okay now? There are many types of pemphigus, but two major types of pemphigus in our practice are pemphigus vulgaris and pemphigus foliaceus. Together, these two conditions, they account for about 90 to 95% of cases. In that group, in that subgroup, pemphigus accounts for majority of cases, especially in Europe and North America, and even in our experience is that bulk of pemphigus patients is pemphigus vulgaris. If you see 10 patients, 9 will be pemphigus vulgaris and 1 will be pemphigus foliaceus. Then, which age group it is commonly seen? It is commonly seen in between 30 to 60 years of age. So there's a wide age range. So you can't precisely diagnose pemphigus just based on the age of onset of the disease. Of course, it's more commonly seen in females than in men. And pemphigus in younger age group, in childhood and adolescent, accounts for um, less than 4% of cases of total cases of pemphigus. So it's not so common in adult and adolescent and children. Now, what is the etiology or cause of pemphigus? So there is a strong genetic background. There's a lot of papers nowadays in various journals, and they have found association between pemphigus and various HLA alleles. So this is one of the alleles that is commonly associated with pemphigus. And when these people who have a genetic tendency to develop pemphigus, they encounter a precipitating factor, which can be depicted like acronyms like pesticides, malignancy, certain drugs, hormones, infectious agent, foods such as foods which contain thiol groups, ultraviolet radiation, and stress. So you have pemphigus. You can remember pemphigus as the triggering factor for this group of conditions. So when a person who is genetically prone to develop pemphigus, when he is exposed to one of these factors, he can develop the overt disease. Now, what is the target antigen in pemphigus? The studies have shown that there are two important desmosomal proteins, desmoglein 1, which is the target antigen of pemphigus foliaceus, and desmoglein 3, which is the target antigen of pemphigus vulgaris. Now, where are these desmogleins present? These desmogleins are present in the transmembranous zone. That is, they connect, a part of the protein is present within the keratinocyte, and a major part of it is present outside the keratinocyte in the intercellular space, where they form scaffolding with the desmoglein of adjacent keratinocytes. So there is a bonding between desmoglein and desmocholine in the intercellular space. So what happens in the disease process? There will be autoantibody production against these proteins. So these antibodies will bind to desmoglein, and then they initiate a cascade of events which ultimately leads to separation of keratinocytes from each other. So this process we all know is called as acantholysis. Now there is homophilic and heterophilic interaction between desmoglein. What does it mean? Homophilic means the desmoglein of one keratinocyte will bind to desmoglein of the adjacent keratinocyte. Whereas heterophilic interaction means desmocholine of one keratinocyte will bind to desmoglein of other keratinocytes. So they can bind in either way. So there is homophilic and heterophilic interaction. Now, if you further dissect it and examine it closely, there is something known as epitope mapping. So the transmembranous part of desmoglein, this part of desmoglein, which is present in the intercellular space, is made up of 5 different molecules, which are named as EC1 to 5. And EC1 and 2, which is present in the amino terminal portion of desmoglein, and this is the target part of desmoglein. Though there are 5 different parts, antibodies in majority of patients will target only these 2 epitope present in the amino terminal end of desmoglein. So what is the importance of knowing this is, if the antibodies are present against some of the other epitope like EC3 or EC4, they are usually non-pathogenic and they do not cause the disease. So in the clinical practice, we might sometimes encounter that a patient is not having the lesion, but he is showing high titers of desmoglein antibodies. So that could be probably because these antibodies in patient serum are targeting these epitopes rather than EC1 and EC2. So that is the importance of knowing the target molecule. The second importance of knowing this is, besides pemphigus, Desmoglein are also the target in Staphylococcus scarlet skin syndrome, which is an infective etiology. The exfoliative toxin released from Staphylococcus target desmoglein, but that is not this EC1 and EC3, EC2. That staphylococcal toxin target EC3 or EC4. So that's a different epitope compared to pemphigus. Now, the beautiful work of Amagai from Japan have shown that the different phenotypic presentation of pemphigus, especially pemphigus vulgaris and pemphigus foliaceus, can be beautifully explained by desmoglein compensation. Am I audible? Can be beautifully
audible. Little more. Can you, if you can be a bit louder, or you can remove your this thing.
I am ready.
This is beautifully explained by desmoglein compensation hypothesis. Now, what does this theory says that in the skin there is high expression of desmoglein 1. The desmoglein 1 is present throughout the epidermal keratinocytes in the skin, whereas in the mucosa there is rich expression of desmoglein 3. Desmoglein 3 expression in the skin is very limited to basal layers or suprabasal layer, whereas in this the reverse holds good in case of mucous membrane, whereas there is very little expression of desmoglein 1. Now, a patient with antibodies against desmoglein 1, what happens is in the skin, because there is high amount of high expression of desmoglein 1, they develop blister in the uppermost layer of skin. In the lower part, they don't get blister because the desmoglein 3 there protects against the compensate for the loss of desmoglein 1. So desmoglein 3 in the basal layer or suprabasal layer compensate for the loss of desmoglein 1. So that is why it is called desmoglein compensation hypothesis. So one desmoglein compensate for the loss of other desmoglein. That is the whole basis of this particular theory. On the other hand, they don't develop mucosal lesions because there is high expression of desmoglein 3. In the skin, when the patient has got desmoglein 3 antibodies, they don't develop skin lesions because there is a protection by desmoglein 1. On the other hand, there is mucosal erosions in patients who have only desmoglein 3 antibodies because it is not protected in the lower part, whereas in the upper part, desmoglein 1 protect against the loss of desmoglein 3. On the other hand, when the patient has got both desmoglein 1 and desmoglein 3 antibodies, they develop both skin lesions as well as mucosal lesions. So this is in a nutshell about desmoglein compensation hypothesis. So in the clinical practice, what does it translate is, if the patient has got only desmoglein 1 antibodies, they will have only skin lesions, as we see in case of pemphigus foliaceus. On the other hand, if they have only desmoglein 3 antibodies, they will have only mucosal erosions. Patients who have both desmoglein 1 and desmoglein 3 antibodies will have both skin as well as mucosal lesions. So this is our typical case of pemphigus vulgaris. This is pemphigus foliaceus, and this is a case of mucosal dominant pemphigus vulgaris. Now, little bit about neonatal pemphigus, why it is not so common. This is because in neonatal skin, desmoglein 3 is co-expressed along with desmoglein 1, which means that there is equal expression of both antibodies. So for a child or a newborn to develop pemphigus vulgaris, mother should be suffering from pemphigus vulgaris and should be having both desmoglein 1 and desmoglein 3 antibodies. Only in that case, they will develop, that will be transferred placentally, and the child will develop the disease. It is very uncommon for a newborn to present only with mucosal erosions or only with pemphigus foliaceus. So it is usually occurs when the mother has both desmoglein 1 as well as desmoglein 3 antibodies. Of course, it is transient and usually subsides in 6 months period. Now, besides desmoglein, there are many other antigens that have been detected, and autoantibodies against these proteins have been implicated in the pathogenesis of pemphigus. For example, the most important one among them is acetylcholine receptor antibodies, which have been detected in about 85% of pemphigus patients. The other novel protein is called pempaxin, which is an annexin-like keratinocyte protein. Antibodies also have been detected against mitochondrial proteins, thyroid peroxidase, and other desmosomal proteins such as desmocolins. So all these proteins might play a role in certain subgroup of patients with pemphigus vulgaris. So based on this, a new hypothesis that is called multiple hit hypothesis have been proposed, which indicates that acantholysis in pemphigus results not only from antibodies to desmoglein, it also could be because of antibodies to some other proteins, which might augment the acantholytic process in keratinocytes. So there are multiple hits both against the structural proteins as well as signaling pathways that initiate uh, pemphigus pathogenesis. The other new concept that have been described is called apoptolysis. So we are all familiar with acantholysis, like we are all familiar with Virat Kohli. Now there is something known as apoptolysis or virashka or Saifina. So it's a combination of two things that have been described. This is called, so what basically this tells us is, there is a combination of two pathogenesis. One is apoptosis, other is acantholysis. Now, acantholysis, we know that it's a separation of keratinocytes, especially in the suprabasal area, and apoptolysis is programmed cell death. Now, both these processes have been identified or described in a patient with pemphigus. Now, it is not clear as of now which one is the primary pathology, whether it is acantholysis or is it apoptosis. But the end stage is there is acantholysis of keratinocytes as well as there is apoptosis. Now, little bit about clinical features. I am sure you are all familiar with different manifestations of pemphigus, so I will not go into the details of different manifestations. Most of the time, oral cavity or mucosal lesions is the first site of involvement, and that is present in about 50 to 90% of patients with pemphigus vulgaris. And almost all patients with pemphigus vulgaris will have mucosal erosions at one point in time. And in fact, some textbooks says that you can question the diagnosis of pemphigus vulgaris if the patient doesn't have oral lesions. Now, which site is commonly affected? It is commonly seen in the buccal mucosa, soft palate, lips, and rarely in the gingiva. So, in the gingiva, when the gingiva are affected, it is usually confined to this papillary tip of gingiva, like around the nails, around the teeth. So, this is in contrast to mucous membrane pemphigoid, where there is more diffuse involvement of gingiva, and that process is called desquamative gingivitis. In pemphigus, this is usually present in the papillary tip of gingiva. It's not common for us to find an intact blister in the oral cavity in pemphigus because of a lot of factors that that can happen there. So most of the time, patient presents with erosions which are irregularly shaped or ragged, and that fail to heal in a short period of time. So this is in contrast to other causes of oral ulcers, whether it is herpes or after stomatitis, which usually heals in a week's time. After a latent period of a few weeks to few months, usually the average latent period is of 5 months, they develop skin lesions in the form of flaccid blisters. They are usually seen in the hair-bearing regions of the body, like scalp, face, and trunk. So the lesions will have a shawl-like distribution, or the lesions are mostly seen over the seborrheic areas of the body. On the scalp, they are present with crusted plaques with fissuring. That is very classical of pemphigus vulgaris. So this is a typical patient of pemphigus who came to us with extensive erosions on the back as well as in the chest. Now, what are the complications that you should anticipate and treat accordingly? one of the most important complication in our setup is, of course, is septicemia. So how will you recognize septicemia in a patient with pemphigus? Uh, they we usually start them on high dose of steroids. So it is not common to find a rising temperature in these patients. So you should always look for increased pulse rate, increase in the respiratory rate, oozing from the lesion. That is very useful clue in patients with pemphigus. If the lesions are not subsiding, or if the lesions are still looking very wet, then that indicates that there is probably underlying sepsis that is not allowing the lesion to subside properly. So we have seen on many occasions that just by changing the antibiotic to a higher antibiotic and keeping the steroid dose or immunosuppressive dose in the same immunosuppressive in the same dose, we could control the disease, or we could initiate the healing process in many patients of pemphigus. So it is very important for you to consider the sepsis part of it before increasing the dose of immunosuppressive in a patient who doesn't respond properly to treatment. So this is one of the patient who had septicemia, and we changed the antibiotic. You can see after 1 month of treatment, most of the lesions have healed, and this is at 2 months, where the crust have fallen off and healed with post-inflammatory pigmentation. Now, little bit about pemphigus foliaceus. Generally, it is considered as a superficial variant of pemphigus, where the blister occurs subcorneally, just below the stratum corneum. Distribution is similar to pemphigus vulgaris. Morphology, because the blisters are very superficial, they occur just below the stratum corneum. It is not common to find an intact blister in case of pemphigus vulgaris. So rather, they present with erythematous, scaly and crusted lesions, mostly in the seborrheic regions of the body. Sometimes they can be generalized and can lead to exfoliative dermatitis, as shown in these photographs. So when the lesion is localized, they can be confused for seborrheic dermatitis or some other eczemas or even psoriasis. And we have had seen patients who was treated by a fellow dermatologist for psoriasis, because the patient had just lesions on the scalp, scaly and crusted lesions on the scalp, and a few lesions around the ear. So it was mimicking like a psoriasis. So it is easily confused for scalp psoriasis. But here the clue is the lesions are little moist compared to the dry scaly lesions of psoriasis. Another useful clue in the diagnosis of pemphigus foliaceus is this sort of peripheral rim of scaling, which is not characteristic, but when it is present, that gives us a clue that this patient is suffering from pemphigus foliaceus, and that occurs because of subcorneal blister, and the stratum corneum, which is peeled off, can result in this kind of polarity of scaling. Now, pemphigus vulgaris involving only the skin and sparing the mucosa is not common, but then there are few case reports, especially from Japan, where patient had typical lesions of pemphigus vulgaris on the skin, but there is nothing in the oral cavity. Histopathology in those patients showed suprabasal split, and those patients were positive for both desmoglein 1 as well as desmoglein 3 antibodies. So this is a rare type of pemphigus. It's called cutaneous pemphigus vulgaris, sparing the oral mucosa. Now, sometimes our patients with pemphigus vulgaris can present with tense blisters. This is experience with some of us also. They can have tense blisters and easily can be confused for subepidermal bullous diseases like bullous pemphigoid. But histopathology in them will show you suprabasal split, and immunofluorescence will show you intercellular staining. Involvement of the palms and soles is not so common in case of intraepidermal blistering conditions such as pemphigus, with the exception of nail lesions. So whenever you have a generalized blistering disease involving palms and soles, if you're suspecting minibullous disease, it is usually subepidermal conditions rather than intraepidermal conditions. Nail is one exception where you can get many nail changes in case of pemphigus, but otherwise involvement of the palms per se is not so common. The fingernails, nail involvement can be seen in about 13 to 80% of the patients. Fingernails are involved more commonly than toenails, and there is wide range of signs, like it can mimic any other nail pathology, starting from acute paronychia to chronic paronychia and loss of nails. And some studies have shown that nail changes indicate recurrence or aggravation of psoriatic pathology. It could be because of the disease per se, or it also could be because of the treatment-related side effects. Now, how do you confirm the diagnosis of pemphigus? It's always better to follow a stepwise diagnostic algorithm, and most of us in the teaching institutions will do Zang test as a academic exercise, and it will show us acantholytic cells in case of pemphigus, or if it is case of bullous pemphigoid, it will show us eosinophils. The next step would be to take a biopsy and confirm whether it is an intraepidermal blistering condition or a subepidermal disease. But the gold standard in the diagnosis of pemphigus is immunofluorescence, which should be done in every patient with pemphigus before proceeding with other investigations. So what are the other investigations that can be done? We can do ELISA, or we can do immunoblotting. Immunoblotting is usually not done in case of intraepidermal blistering conditions, whereas ELISA is commonly done to confirm the diagnosis. So as I said before, the gold standard test in the diagnosis of pemphigus is immunofluorescence. The diagnosis should of pemphigus should be seriously questioned if the test of DF is negative. This is the statement in some of the standard textbooks, and it is usually shows you an intercellular staining like this in a fishnet or chicken wire appearance. It's usually seen with IgG class of immunoreactant. When the disease is very active, C3 also may be positive. Other class of immunoglobulins such as IgM and IgA may be positive in about 20% of the patients. Now, can it be used to, the next question is, can immunofluorescence be used to classify pemphigus into pemphigus vulgaris or foliaceous? The answer is no. You can't base the classification of pemphigus based on immunofluorescence report. But occasionally, we get to see a biopsy sample which shows a classical suprabasal cleavage. You can see here the basal keratinocytes here, and the entire epidermis is lifted up. So there is a suprabasal split. This is the case of pemphigus vulgaris. On the other hand, in case of pemphigus foliaceous, the staining pattern is more intense in the upper epidermis, and as you come down towards the basal layer, the staining pattern becomes less intense. So this is an indirect clue to tell us that this patient is probably suffering from pemphigus foliaceous rather than pemphigus vulgaris. Now, if the patient doesn't agree for biopsy, we can pluck the hairs and demonstrate the intercellular staining pattern. This study was done about 10 years back from our department, and we could demonstrate intercellular staining in the plucked hair in about 85% of our patients. So similar studies have been carried out in many other parts of the world. Now, if the facility for immunofluorescence is not available in your clinic, so what will you do? So you have to send it to the center where immunofluorescence is done, but that has to be done using a specified media called Michel's media. So even Michel's media may not be available in your clinic when the patient is there. So you started your clinic, started your practice recently, and you have a new patient of pemphigus vulgaris. You want to take a biopsy, but you don't have access to Michel's media. So what you can do? So we demonstrated the utility of honey as a transport medium of DAF samples. So we procured honey which is procured from the general stores or departmental stores was used in this study. Initially, we did a pilot study that was published in Journal of American Academy of Dermatology. And then subsequently, we compared it with Michel's media and found out that biopsy samples will retain the immunoreactant for up to 2 weeks, beyond which there is progressive deterioration of immunoreactants. So honey can be used to transport the biopsy samples directed for immunofluorescence test. So one important thing that you should remember is, because honey is more viscous than Michel's media, you need to make sure that your biopsy sample is properly immersed in honey. And if you read this article, we have described a sort of sandwich technique where you pour honey, take honey in a vial and place the biopsy sample on that, and then again pour a little bit of honey on top of that, so that biopsy sample is properly sandwiched between two layers of honey, so that the proper moisture content of the biopsy is maintained and the immunoreactants are not lost. Um, Now, the next step in the diagnosis is a serological test. So once you confirm the diagnosis of pemphigus, the next step would be to detect the circulating antibodies, the antibody burden in the patient's body. So that can be done by two tests. They are ELISA and indirect immunofluorescence. Now, between these two tests, ELISA is preferred because it is quantitative test and it is not observer dependent test. It also gives us phenotypic correlation, as I mentioned earlier. So if your patient with pemphigus foliaceus will have desmoglein 1 antibodies, mucosal pemphigus will have desmoglein 3 antibodies. However, rarely patients with pemphigus foliaceus might have desmoglein 3 antibodies, and mucosal pemphigus may have desmoglein 1 antibodies. So in that case, you start thinking whether you have missed any clinical clue, or whether the patient is going to develop pemphigus from pemphigus foliaceus to pemphigus vulgaris. The answer is no. It can happen sometime in your patient, so need not worry about that. Most important thing there is the clinical clue. If the patient has got only desmoglein, patient has got only skin lesions, you still can label them as pemphigus foliaceus even if the antibody profile is showing desmoglein 3. So the other advantage of ELISA is they correlate with the disease activity, though the correlation is not very perfect. For example, desmoglein 1 correlates better than desmoglein 3. So when you start the patient on treatment, the desmoglein 1 levels comes down faster compared to desmoglein 3. So in other words, so you can conclude that persistent of high levels of desmoglein 1 has got positive predictive value, which means that if the levels of desmoglein 1 is high, then the chance of patient relapsing is high. On the other hand, persistent of desmoglein 3 antibodies doesn't necessarily indicate a mucosal relapse. So antibodies can be used to monitor the disease activity in a given patient, but you can't compare the antibody level of two different patients, which means that if the patient A has got 130 desmoglein 3 antibodies, in the patient B has 150 international units, it doesn't mean that patient B has more severe disease. So you can't compare the antibody profile between two patients, but in a given patient, with the treatment, the antibody levels should gradually fall or decrease. However, of late, we have been seeing some consultant getting confused with the desmoglein report. So you should always make final diagnosis based on your clinical diagnosis, pathological, immunopathological findings, and then serological findings. You don't base the diagnosis only on serology or only on some other test. So I will explain why you should not do that. This is because 50% of the patients, the first degree relatives of pemphigus patients, will have a positive ELISA. Even in the absence of clinical disease, they can have circulating antibodies. So this is something like antinuclear antibodies that we often tend to find in a normal population. You should never base your diagnosis only on serology. So that is why serology should not be done as a first step in the diagnosis. It should be a complementary test for other investigations. Minority of bullous pemphigoid patients may have desmoglein 3 antibodies. Also, sometimes will have desmoglein 1 antibodies. So borderline positivity should be interpreted very carefully, and it could be because of non-pathogenic antibodies due to epidermal damage, a phenomena which is known as epitope spreading phenomena. So I will just explain to you in this case scenario. This was published in British Journal of Dermatology. So you can, this is an elderly man, 89-year-old patient who had resistant, sorry, there's a spelling mistake, mucocutaneous disease. He had erosions on the mucosal surfaces, tens to flaccid blisters on the skin, and histopathology showed subepidermal blister. Direct immunofluorescence showed linear BMZ band consistent with the diagnosis of bullous pemphigoid. Indirect immunofluorescence showed epidermal staining pattern. However, his LSS showed desmoglein 3 positivity, which indicate that this is pemphigus. He was also positive for BP180 and BP230. Now, when you see such patients who has mucosal lesions, who has got skin lesions, and was positive for desmoglein 3 antibodies, you start thinking whether the diagnosis of immunofluorescence was right or not. So, in this study, authors have done immunoblotting, and then they confirmed that this patient antibodies reacted only to BP antigens and not to pemphigus antigens. So a final diagnosis of BP was made. So these are some of the pitfalls in the diagnosis if you rely too much on serology alone and don't take the holistic approach of looking at the other findings. So in brief about the treatment of pemphigus, so there are international guidelines which have been proposed recently and modified of late. And according to that, we have two phases in the management of pemphigus. We have an induction phase and a maintenance phase. The induction phase, you induce the remission. So that can be done by controlling the disease. So in this phase, you need to be very aggressive, start the patient on steroids and continue it till patient doesn't develop any new lesions or existing lesions begin to heal. So that is the phase, you call it as control of the disease or disease control. Then the next phase is consolidation phase, where you want to consolidate the process of disease control. So this is continued at least 2 weeks, continued for at least 2 weeks when the patient doesn't get any new lesions or more than 80% of lesions have healed. So these are the two phases of induction phase. So you start the patient on steroids or immunosuppressive agents, then maintain the patient till the end of consolidation phase. So once they have completed the consolidation phase, then you start tapering the doses of steroids in the maintenance phase. So the basic goal of treatment of pemphigus is to hit it early and hit it hard. That means that even if the disease looks very mild from outside, they may be harboring a lot of burden, antibody burden in their blood. So it is always ideal to treat it aggressively initially. And once the consolidation phase is reached, then you can start tapering the doses of steroids. So the simple algorithm is something like this. This is something that we follow in our department. So start the patient on prednisolone, 1 milligram per kg body weight per day, and continue to continue that. And if the patient continues to develop new lesions, then you have different options. If there are no new lesions, then you start tapering the dose of steroids. Taper it rapidly initially, say for example 10 milligrams every 2 weeks till you reach 30 milligrams. After that, the tapering should be very slow, 5 milligrams every 2 weeks. If the patient continues to develop new lesions, then you can consider increasing the dose of steroid to 1.5 milligrams, or you can consider giving dexamethasone cyclophosphamide pulse therapy or Dexona pulse therapy. You also can add immunosuppressive agents like azathioprine, mycophenolate, or cyclophosphamide. Or the preferred treatment nowadays would be to give them rituximab. So there are two protocols. I'm sure you all know about this. You have rheumatoid arthritis protocol and you have lymphoma protocol. So I will not go into the details of this. But when do you want to start the patient on immunosuppressive agents? Typically, these immunosuppressive agents are slow-acting medications, and it is ideal. The ideal time to start them is from day one, because they usually take about 4 to 6 weeks to begin their action. So, about six studies have shown that about 60 to 80% of patients with pemphigus will relapse, especially when you start tapering the doses of steroids. So, to overcome that, if you start the patient on immunosuppressive therapy, as shown here. So in the induction phase, you start the patient on steroids, a high dose of steroids, and then once the consolidation phase is ending, you start tapering the doses of steroids. And it is during this phase that most of the patients will develop relapse. So to overcome that, you start the patient on immunosuppressive therapy from day one. They usually take little time to act, about 4 to 6 weeks. So by the time you start tapering steroids, the immunosuppressive treatment or adjuvant treatment would have started in their action, so that a prolonged remission can be achieved. Now, few words about follow-up of patients. Um, how do you taper the dose of steroids? When the patient has got active clinical disease, it should be based mostly on the clinical activity of the disease. So every time when the patient comes to you, you examine the patient in detail, look for the cutaneous signs, look for the mucosal signs, and then elicit the two important signs, Nikolsky sign, especially the marginal Nikolsky sign. If it is positive, that means that the disease is active. So, but when the patient enters into the phase of clinical remission, when there are no lesions, then further tapering of dose of steroids should be based on either indirect immunofluorescence or ELISA. So ideally, these tests should be repeated once in 3 to 6 months period, and is decreasing titer or lowering titer is a good sign of control, whereas if the titers are going up, that indicates an impending relapse. Now, the other common problem that we often encounter in our practice is persistent of oral lesions. So, though most of the skin lesions will heal faster, patient will have few isolated lesions in the mouth or in the oral cavity. So, what is the other treatment options for such patients? So, there are many reports of late where authors have used intralesional rituximab in the treatment of refractory oral pemphigus. So, this one is from PGI, and there is one comparison study between intralesional rituximab versus intralesional triamcinolone in the treatment of refractory or resistant oral lesions. So these are some of the things that we can do in our practice. And one of the novel treatment in this report, this published in Journal of American Academy of Dermatology, where authors have used trichloroacetic acid for persistent mucosal lesions of pemphigus. So you can see the improvement. There's persistent lesion here, and they've done cauterization using TCA, and that's completely healed according to authors. So, but very important here is you should not do this when the patient is getting high dose of steroids. This should be attempted only when when the disease is controlled on minimal therapies. So this particular patient was on a daily dose of steroids, about 5 milligram per day. So you should do only when the disease is well controlled. You should never attempt when the disease is very active. Few words before I wind up about subepidermal conditions. Subepidermal immunobullous diseases are heterogeneous group of diseases. As you can see here, they all present with dense blisters. Histopathology will show you subepidermal cleavage with polymorphous cells. If the eosinophils are there, then you would label it as bullous pemphigoid. If there are more neutrophils, you will label it as linear IgA disease. Immunopathologically, BAF will show linear BMZ band in all these patients. So the precise diagnosis of these conditions, subepidermal conditions, is a great challenge. So this picture, I'm sure you would have seen in the standard textbook. So each of these conditions can mimic each other. So we need to be we need to have an open mind before arriving at the diagnosis. So there are many instances where if you base your diagnosis mostly on the clinical grounds, you are likely to make a wrong diagnosis. So some of the factors that we consider is age of onset. If your patient is a child of less than 10 years, you would put linear IgA disease as the first possibility, EBA as the second, and bullous pemphigoid as the last possibility. On the other hand, in young adult, you would consider the diagnosis of dermatitis herpetiformis. A middle-aged patient presenting to you with subepidermal tense blisters, you would consider the diagnosis of linear IgA disease and epidermolysis bullosa acquisita. In the middle age, between 50 to 60 years, anti-P200 pemphigoid will come as the first diagnosis, followed by EBA and then bullous pemphigoid. Elderly patient after 60 years of age, bullous pemphigoid is the first possibility, anti-P200 pemphigoid is the next probable diagnosis. So this is one of our patient who 10-year-old girl who presented with multiple blisters, mostly on the trauma-prone areas. She was diagnosed outside as a case of linear IgA disease, but when we saw her, you could see here lesions are mostly present over the trauma-prone areas, a typical mechanobullous phenotype. So we made a diagnosis of epidermolysis bullosa, and you could see here linear BMZ band going to the floor in the split skin. We published this in Indian Journal of Dermatology. So you should have an open mind to make those diagnoses. So if your patient has got predominantly mucosal lesion, you would consider the diagnosis of MMP. On the other hand, mucosal lesions can also be seen in association with skin lesions in linear IgA disease and many other conditions in varying proportions. So all these conditions can have mucocutaneous disease. So we give a lot of importance to itching. So this particular patient who presented to me with persistent itching, he had no other skin lesions except for xerosis for about 6 months. So he was treated initially for senile pruritus with a lot of emollients, and one fine day after 6 months of treatment, he developed one small blister on the leg. So this is the prodromal. What he had actually is a prodromal stage of bullous pemphigoid. And finally, he developed bullous pemphigoid. We could confirm the diagnosis by doing direct and indirect immunofluorescence. So this is another interesting patient of ours who presented with intense itching all over the body. She was treated earlier for scabies and many other with topical steroids, and a diagnosis of prurigo was made. She was treated with for scabies, but her itching did not subside. So we thought, why not take a biopsy? So we took a biopsy, and to our surprise, there was a linear staining of BMZ with IgA. And then we did a serration pattern analysis, which showed us n-serrated pattern. So this was a case of linear IgA disease presenting as chronic prurigo. So this is a atypical presentation. So again, direct immunofluorescence can help you in arriving at the diagnosis. The other important sign that we often tell our PGs is to look for milia formation. So whenever there is tense blisters with milia formation, you would always consider the possibility of epidermolysis bullosa acquisita. And even these patients will have some sort of nail changes as this patient, you can see nail dystrophy, milia formation, they are consistent with the diagnosis of epidermolysis bullosa acquisita. But we should be aware of the fact that not all patients with milia will have epidermolysis bullosa acquisita. For example, this patient of ours, a young lady of 34-year-old who presented with tense blisters, and she had her immunofluorescence showed a roof staining pattern. You can see here, there is a linear staining of BMZ going to the epidermal side of the split. So she was suffering from bullous pemphigoid, but when the lesions healed, she had a lot of milia formation on the leg. So milia formation, though not so common, can be seen in many other subepidermal immunobullous conditions and even in pemphigus. So that is not a very classical finding, but if it is present, that goes more in favor of EBA rather than many other conditions. Again, we give a lot of importance for this particular sign, string of pearl appearance, or crown of jewel appearance. I would re-emphasize the fact that this is very classical of childhood linear eye disease, but when it is seen in adult, this can be seen in many other conditions, including bullous pemphigoid. So this is a case of bullous pemphigoid. You can see the blisters arising on erythematous base. So it's a classical case of bullous pemphigoid, but showing a string of pearly appearance. So don't base your diagnosis just by one or two signs. So this is an interesting case in middle-aged lady presenting with blisters, mostly on the mostly confined to the face. She had a little bit of scarring there, tense blisters. So this is a case of Brunstring pemphigoid, which is an uncommon type of EBA. So there are very few reports of this particular type. So the target antigens for this particular type of disease is not been identified, but the recent literature says that it is mostly targeting type 7 collagen. Majority of these cases are negative by indirect immunofluorescence also. So to give you summary of subepidermal immunobullous conditions, how you will go about in diagnosing. So if you can see either linear BMZ band or granular IgA band on immunofluorescence. So if you see granular IgA band, the diagnosis should be dermatitis herpetiformis. On the other hand, if your patient has only IgA, linear IgA band, the diagnosis would be linear IgA disease. The problem is when they are positive for both IgG and C3, then the next step would be to split the skin and see if the band is going to the roof or to the floor. So if you see an epidermal type of staining, or we call it as roof staining, that would be consistent with the diagnosis of bullous pemphigoid. On the other hand, floor staining pattern is not characteristic of one particular disease, and it can be seen in all these conditions. It can be seen in EBA, bullous SLE, laminin 332 type of MMP, and anti-P200 pemphigoid. So you need to do additional test in the form of serration pattern analysis, ELISA, immunoblotting, and antigen identification using epidermolysis bullosa skin. So if the patient has a bullous pemphigoid, then you can do either BP 180 or BP 230 ELISA. So this is a sort of algorithmic approach for the laboratory diagnosis of immunobullous, subepidermal immunobullous disease. So I want to conclude by showing this case to you. This is interesting case of an elderly man who presented with tense blisters. So we thought because he was elderly and he had tense blisters, our first diagnosis was bullous pemphigoid. We were happy when we saw his immunofluorescence, which showed linear BMZ band. But when we did indirect immunofluorescence, it showed dermal binding pattern. Instead of, if it were to be bullous pemphigoid, you would expect the band to be on the epidermal side of the split. But in this patient, the band was on the dermal side of the split. So we revised our diagnosis into inflammatory EBA. But 75-year or is not the common age to get EBA. So we collaborated with other people from Germany, and we could confirm the diagnosis of anti-P200 pemphigoid in these patients. So we did a series of cases and published it in Indian Journal of IJDVL. And in our series, there were 3 cases of anti-P200 pemphigoid, and this is probably the first report from India to confirm the diagnosis of anti-P200 pemphigoid. So it is not that this particular disease, which is mostly described from Japan and Germany, it's common in our country also. Probably we are not able to detect because it clinically as well as immunopathologically mimics either bullous pemphigoid or EBA. And it's very important to diagnose these conditions because they often respond to dapsone monotherapy, and you did not give aggressive systemic steroid therapy. So our work was recognized and it was published. I mean, some other authors have also quoted our work. So to conclude, autoimmune bullous diseases pose diagnostic as well as therapeutic challenge. You need to have a stepwise algorithmic approach to arrive at the final diagnosis. always your clinical finding should be correlated with immunopathological as well as serological studies. So thank you very much again, and thank Dr. Mathur, Dr. Lalit Gupta, and US Agarwal, sir, for giving me this opportunity. If there are any questions, I'll be happy to answer. Thank
Thank you
you.
very much. Thanks a lot,
Thank you,
Doctor.
sir.
Thank you very much. Will you please stop sharing, or shall I do it? Right. So before we start sharing the questions and all these things, as per our routine, let me offer you this thing. Dr. Lalit, can you please offer a
Yes, sure, sir.
virtual
Sure, sir.
felicitation?
Sure, sir. It is indeed my pleasure, Dr. Rao, to listen to you and listen to you this virtual memento. And it was wonderful talk. I am sure all the postgraduates must have been immensely benefited by
Not only
your.
postgraduates, but the consultants also.
Yes,
We have got
sure, sir.
almost
Yes,
50.
yes, sir. Everybody, including postgraduates, must have been immensely benefited by your excellent talk. And please accept this on behalf of the Dermatologist Consortium of India, which Professor Mathur is so closely monitoring and making it a hit show.
Thank
So
you, sir.
accept it.
Thank you very
Thank you very
much.
much. Thank you very much.
Now the question answers are here. Dr. Lalit, can you see the chat box? And
Yes, sir.
right.
Yes, sir. I can see it. And before I start reading the questions, I'll just summarize what not summarize, but just a few points that I would mention. That indeed it was a excellent talk, sir, and you drove home several key points in a very simplistic manner, and they were great. Particularly of note were your mention of the epitope mapping in relevance to pemphigus and SSSS, desmoglein compensation hypothesis, and other antigens that are involved in the pathogenesis, multi-hit hypothesis and its clinical relevance. Apoptolysis was something that it was something new to many of us. Then control of infection does control the pemphigus activity. This is a very common clinical finding, and we must be aware of that if you control the infection nicely, sometimes the pemphigus activity gets controlled, and do not unnecessarily increase the dose of corticosteroids and immunosuppressants in your patient. Then immunofluorescence in plugged hair is a useful diagnostic tool if you want to obviate the need for the skin biopsy.
That was very interesting.
Utility of honey as a transport medium in a replacement of Michel's media. It's a very cheap and easier method to go for this, because many times the Michel's media is not available at many places. You also mentioned about the 50%.
But how about in normal saline also? Dr. Raghavendra, did you?
Yes, I think yes.
Normal saline.
He will
Normal
shed
saline,
more light on that. Yes, he will shed more light.
24 hours, it has to be shipped to within 24 hours. You can't, yeah.
Even if you don't have anything, then you can immediately put it in normal saline.
Normal saline, 24 hours only, sir. If you can ship it within 24 hours, you can do that.
But otherwise, from normal saline, it can be shifted to Michel's media or to honey.
Yeah.
Well, I have sent biopsies to Dr. Raghavendra several times, and I remember that this your linear IgA dermatosis, which is one of our case, which was being treated like a prurigo and other things, which came out to be linear IgA dermatosis.
In fact, the diagnosis is mainly immunofluorescence based these days, and many centers do not have the facility actually for immunofluorescence.
No, but they are doing a nice job.
I know.
Work,
I know.
and probably on a very reasonable 1,500 rupees. They give a very good this thing.
So you also mentioned about an holistic approach in diagnosis as well as treatment of these patients, and nicely explained the algorithms of the pemphigus vulgaris and subepidermal bullous diseases. So it was, all in all, it was an excellent and wonderful and useful talk for all of us. And we have some questions. In fact, a lot of questions are there in the chat box, and we'll take them up one by one. Somebody is asking how to process the specimen and honey. I think you mentioned about it, the sandwich technique.
Yes.
Yeah.
Then elaborate on the follow-up of pemphigus on systemic steroids. You also took up this issue in the talk, maybe why MMF has fallen out of compared to the azathioprine and cyclophosphamide, that someone wants to ask. Biju wants to ask, Dr. Biju Vasudevan wants to ask about more details on the last case, which was very interesting. So maybe we could take up the last case, some more details on that. Dr. Biju Vasudevan wants to know that.
The last case was anti-P200 pemphigoid. So the diagnosis of anti-P200 pemphigoid is very difficult. It will immunofluorescence. It will show BP-like picture. Histopathology. It will show linear IgA-like picture because there will be subepidermal blister with neutrophils. Confirmation of diagnosis can be done only by immunoblotting or ELISA, which is not available routinely. It's available only in research labs. But of late, there are certain techniques that have been developed based on immunofluorescence. So, for example, if your patient has a floor binding pattern, then you can consider either epidermolysis bullosa acquisita or anti-P200 pemphigoid. Now, how do we differentiate these two conditions? By serrated pattern analysis. So, serrated pattern analysis is something that has been described by people from Netherlands. And in epidermolysis bullosa, it will show a U-serrated pattern, whereas anti-P200 pemphigoid will show N-serrated pattern. So, a floor binding with the N-serrated pattern, the diagnosis is anti-P200 pemphigoid. A floor binding and a U-serrated pattern diagnosis is EBA. So we can actually make a distinction based on immunofluorescence and diagnose anti-P200 pemphigoid. I hope it is a little bit.
Hello, can I
ask about the strength of TCA in the study?
Yeah, 33%. Dr. Smith has already replied to it.
Someone wants to know about the follow-up of patients on pemphigus. If the immunofluorescence and ELISA techniques are not available, how do you monitor these patients clinically?
You mean as long as patient has got clinical activity, it is based on the clinical activity. Yeah. But when the patient enters into the phase of remission, that is the time when we actually need to do serological test. So ideally, I mean, nowadays many labs are offering these services. So you can ask somebody in some of the labs where it is done. Ideally, according to the recommendation, we need to do serological investigations, either desmoglein ELISA or indirect immunofluorescence. Otherwise, it will be very, otherwise it will be very sort of, we can't, there is no guide for us to taper the dose of steroids. It is just becomes very vague.
Because all through we have been doing that without the support of serology and immunofluorescence test, because that is available only at a few select centers.
Nowadays, many are offering, sir. Many centers are offering.
What should be the treatment protocol in pemphigoid gestationis? Somebody has wanted to ask.
Yeah, Subodh's question, I saw that. Pemphigoid gestationis, you need to give steroids because it is usually in the third trimester or second trimester. So steroids are safer. You can give steroids because unless you give steroids, the disease will not come under control. Azathioprine is something that can be safely used during pregnancy, but not other drugs. So steroids with or without azathioprine can be used.
Somebody asks about role of banana leaves in management. It's always a discussed thing.
Many conferences they have discussed, and we also have used banana leaves as a dressing. We found it to be useful, but then there is an infection control committee in the hospital, and they will not let you use them for a long period of time. So you need to take that.
Any role of blood transfusion in acutely ill cases of pemphigus vulgaris? Role of
plasma paresis has been tried. I am not sure about the blood transfusion. Why do you want to do blood transfusion when the patient's hemoglobin levels are normal? I don't know. Okay. But plasma paresis is something that has been tried. Immunoabsorption is something that has been tried in Germany.
Okay. Can you process the zinc smear for immunofluorescence study?
Yes, that has been done. That can be done. Zinc smear immunofluorescence can be done, and it will show acantholytic cells.
About this hair immunofluorescence, any further light on it?
Yes, sir.
Plucking hair.
Yeah, in that study we plucked hairs, and it has to be anagen
Very
hairs.
interesting.
Yeah, it has to be only anagen hairs. It should, I mean, we tried only anagen hairs in that particular study. So we plucked hairs and examined under light microscope initially, make sure that there is outer root sheath, and then we stain it with FIT6 conjugates. So we did that, and then we followed up those patients, and we found that we followed about 6 patients. Periodically, we did direct, indirect, and hair examination in about 6 patients, and we found that hair can be used as a substrate for monitoring the disease activity also.
You didn't say anything about paraneoplastic pemphigus.
I think there was
You didn't utter a word on it.
Yeah, I think there was a whole lecture on that. Dr. Sanjeev Handa has already given.
Yes, it was the first of this series on 1st of June. So
I purposefully skipped that because that was already dealt with.
Yes.
But your presentation was superb, top class.
Thank you, sir.
Sir, Balbir,
can you use saliva as a diagnostic tool?
Saliva, yes, sir. Saliva has been used as a diagnostic tool both for the indirect immunofluorescence and ELISA.
Biju is coming. Biju wants to ask anything. Biju, I can see Dr. Soman Peter, Dr.
P200. Just P200 also respond the same way to treatment?
Yes, sir. It actually doesn't require high dose of steroids. You can manage P200 with either low dose of steroids or dapsone. So it has got a better therapeutic outcome compared to epidermolysis bullosa acquisita, even though both are floor binding conditions.
Excellent presentation, sir. Excellent presentation.
Thank you. Thank you very much.
Dr. Niranjan Nagpur, sir. Where is Dr. Niranjan Nagpur? His question is pending.
We are missing today.
Soman Peter, who are you? Can you unmute yourself? Dr. Soman?
Sir, you are in collaboration with Balbir Pugal?
Yes,
He's died. He's not alive anymore.
Yeah. He actually.
I knew him for last 35 years.
Yeah. Yes,
he died about 2 years ago.
Yes, Balbir Pugal used to come to Mumbai several times. I've been there.
He's the man who brought immunofluorescence into this country.
Yes, sir. So he was with us for 1 month before he left to UK, and within 1 month he passed away.
Yes.
It was in 2016 after the Coimbatore Dermacon. He came to Coimbatore Dermacon, and then he came to Manipal. He stayed with us for 1 month.
Wonderful man, top class.
Yes, sir.
Well, a very nice lecture and a very nice interactive session. Thank you.
Thank you, sir.
Thanks to all.
Thank you, sir. Thank you.
We can call it a day. Thank you. Thanks a lot. Good night.
Thank you, sir. Good night. Stay safe. Bye.
Good night. Thanks a lot, sir.